So true. So true. 2 more minutes.
I use my 60 seconds to. Wait, is it 6 and lower 8 or is it 8 and lower 6? See, I'm like, it always happens to me.
You're gonna do great.
Hey, I don't need your positive affirmation. Second question's bothering me.
6, 9, 10, 13, 14, 19, 23.
What are your plans this weekend?
What are my plans?
What are your plans?
Well, we have an out-of-town guest, so I have to play host. I play pickleball on Sunday. Can't do without that. That's it. That's my plan.
You're not going to study for the exam about this?
Exam's written. I'm done. I got a free day on Monday.
You ever just take it for funsies?
I write it, so does that mean I've taken it for funsies?
I guess so.
Yeah. A little bit.
How do you know if you know?
Yeah, that's always the $64 question. How do I know that you? Okay, so we have done it's the first time in, I don't know, the 17 years I've taught this class, have gone ahead and done all the lectures before all the lectures. So now I'm stuck with how to entertain you guys for this hour. How is it that you want this to work? Do you want me to go over? I've left this blank so I can throw up any previous slide, a lecture slide, or we can just talk. You can just ask me questions. How do we want this to work? Plus, you're my biggest class, so you're my biggest unknown. I usually generally know how well the class is going to do in the exam. You guys are more of a mystery. Yes?
Oh, I was hoping that you would do questions. I thought that's what it would be.
Me give you questions.
Or like, no, like we give you questions.
Yes.
Because I'm already thinking some ready.
Yes. Well, I'm happy to answer your questions, so hit me with the questions.
Okay.
All right.
Can I go ahead?
Yep.
Okay. I just was confused about. So I get all the association fasciculitis or fasciculi, all the stuff connecting it.
Yep.
So do we just have to know like this? So like the cingulum connects it's like the limbic system to the cingulum gyrus. Is that
Okay.
it? Or do we have to know like specific things like if it's lucid?
Yeah, sort of. Let's do this. Let me just get a big blank. Nothing up here. Okay. The thing to remember about our connective passages or connective fiber pathways is there's 2 distinctions. What are the first 2 distinctions, Michael, that I separate my connective pathways? How do I divide them in large groups? They are either commissural, which means
across the hemispheres.
Okay, or they're
Association
which means
within the hemisphere.
okay. So within the associative, which means staying within a hemisphere, we had a number of different fiber bundles. We had the arcuate, like the, who can tell me the other name for the arcuate fasciculus? Superior longitudinal fasciculus. And what lobes would the superior longitudinal fasciculus provide information to?
All of them.
Okay, give me an example.
Frontal, parietal, temporal.
Right, so you just follow the pathway. So you just have to remember, none of these pathways, the corpus callosum, anterior commissure, here is my arcuate fasciculus, right? And remember, there's always somebody getting on and getting off along the pathway. So even if this was the cingulum, which is a little more, it's a fiber bundle pathway inside the cingulate gyrus, right? The cingulate gyrus is the gray matter that's sort of wrapped around the cingulum. And so the cingulum is a little bit more kind of a simple shape. But remember, there's all kinds of stuff jumping on and off. So something may never make it to the other end of that fiber bundle. Don't think of it as a point A to get to point B thing. It's not like that. So to your question, it would be something like, which areas of the cerebral cortex could access this to get to or send projections to another location. So you're just trying to remember the shape, right? So the superior, inferior, occipital, parietal, or frontal, occipital. I mean, in the name, it tells you where it's going. So you can, and then of course, almost anything. We could just randomly pick stuff out of a bag. Yeah, it probably uses that momentarily, gets on and gets off that white fiber bundle. So does that answer your question?
Yeah.
Awesome. Felix?
Is the argument only in the dominant, or is it
Nope, it's on both sides.
Okay, great.
Association fiber bundles are symmetrical. Yep.
Thank you.
Who else?
When we talked about infarcts in lecture, we didn't go as in detail as the one slide that you have that goes very much in depth.
Oh, yeah.
So I was wondering if you want us to know.
No.
Okay.
So that chart, it'll come in handy, that chart, later when we get to cases, but that's to just sort of, I don't know, I just thought might find it fun. But you don't have to memorize that chart yet. But it will come useful, so know where it is, right? When you start hitting the patients, you might want to refer back to that chart. Okay? Any other questions? All right, we're feeling lost. Let me try to rein you in. Let's go back to our first lecture. Are we good on the many ways that we can categorize and classify the brain? We had the developmental. We're kind of good with that. We've got the histological. That's Corbinian in his Brodmann map, right? And we have the gross. And we're going to interchange those names all the time. As many times as we can, learn your Brodmann's areas. And they're the ones that I just bring up over and over and over again. So they're not the map. You don't have to do the 50 areas that the map shows, but the ones I keep mentioning. Motor is 4 and 6, sensory 3, 1 and 2, vision, Owen.
16, 17, 18.
No, add a number to all of them. 17.
18, 19.
Yes, 17, 18, 19. Those are visual cortices. Who's in my auditory?
41, 42.
Right. So these are the ones we talk about. Broca's. Who knows Broca's?
44, 45.
44, 45. Who knows Wernicke's?
22.
See, that's pretty much all. And then I gave you a small number of the association areas that do some funky things that I thought was interesting, would show up in cases later, which is why I had to bring them back out. And so, right-left confusion, so 38, 40, so we had a couple random ones. But other than that, that's kind of how we said. Michael?
So we're not going to be quizzed on like 40 or anything?
Well, 40 is one of the small random numbers, yeah.
So can you explain that one? Because I couldn't understand like what it did.
Okay. So let me make sure I get them all. And I can never remember. So I gave you, I gave you 3 extra ones. So I gave you Brodmann's area 8 and lower part of 6, lower part of the motor field. And this was frontal eye fields. So Brodmann's area 8 and lower parts of 6 are frontal eye fields, FEF. They drive both eyes to the opposite side. That's their function. So if you have an infarct in that spot, you don't have the drive, and then the drive from the opposite side is overly strong, so your eyes are kind of constantly looking to the lesion side. So let's say I damage my right frontal eye field, my eyes will be kind of stuck looking towards the right, and I'll have difficulty bringing them back because of the frontal eye field on the right side is damaged and can't counter the push that's coming from the left frontal eye field. So they keep it in balance, and they have a tug of war a little bit in terms of how you can move your eyes. Now, fine control, detail control, a lot of voluntary control is not coming out of your frontal eye fields. They're not really that responsible for it. You have extraocular muscles driven by your cranial nerves that really control that. So these are just big pushes. Yeah.
So your eyes are stuck in the direction of where the
Lesion, the
is,
side of the lesion.
because the opposite side is
Yeah, the opposite side is unopposed.
okay.
Right, because normally things have to be in balance. So remember, you have two frontal eye fields, each pushing in the opposite direction. When one is missing, there's no opposition, so the eyes go towards the side of the lesion. Make sense? Make sense? Awesome. Who's next? Oh, yeah. The other one is the Brodmann's area 39. Okay, and this is the one where it's possible to get alexia and agraphia, but no aphasia. So we have been saying that alexia is a great litmus test for Wernicke's, right? Because it's our ability to read, our ability to understand language is all comprehension. And agraphia would be equivalent to maybe damaging Broca's as a Broca's aphasic because it's a production component. But there are elements of reading and writing that can be separated away from language comprehension. So in this case, if you damage Brodmann's area 39, it's only specific to reading and writing. It wouldn't be speaking or understanding language. So aphasia is off the table for these individuals. There's nothing wrong. They're not a Broca's or Wernicke's aphasic. They just can't read and write. Okay. The last one I gave you was more complex. Brodmann's area 40 sits on the very top ridge of the temporal lobe in the supramarginal gyrus, and it does some very association combo deficits. For example, you have tactile agnosia. Tactile agnosia means I cannot identify anything by touch. So if I put my hand in a bag and felt around for some objects, a paper clip, a pen, etc., I would not be able to identify them. I don't have the inability to feel them. I'm not numb. I just can't associate the object with the sensory information. So that's tactile agnosia. You would have left-right confusion. Show me your right hand. Show me your left hand. They're just not knowing which is left or right. That concept of left and right is somewhere in your brain. So it looks like 30 or 40 is impacting them. Disturbances in body image. Are my shoulders above my elbows?
Yeah.
Are my elbows above my knee? Where is my knee? Where are my toes? I may have difficulty with identifying or giving body names, body part names, or I might not understand their proportional relationship with each other. So I have a body image issue. So that also comes out of this area. I can have apraxia. Yes, Michael?
So you have the proprioception, you just don't know what it is.
You have difficulty using proprioception to inform you on these. So you don't have visual problems, you don't have sensory problems, but you have difficulty using those types of information to then make an even more complex identification. Okay? Kind of just like primary cortex just gives you plain out, it's either motor or sensory, but then we have supplementary or associated cortex that adds more complexity. Okay?
These are all 40?
These are all 40.
Okay.
Did I leave anybody out? The apraxia, which is that purposeful movement based on how the object interacts with you. Scissors, blowing out a candle, how do you operate a lock and a key? Making these motions tell you, one, I understand the concept of lock and key, and then I understand how to motorically interact with them. What are the motor movements that I need to use to interact with them? Okay. All right. What else? Yes, Owen.
Do we need to know the pathway of blood flow throughout the whole atrial system in the brain?
Yes.
Should we be able to track it throughout the whole brain?
The blood or the cerebral
The
spine?
blood.
Which one?
The blood.
So I don't need you to trace it, I need you to know the territory associated with each arterial bed. So, yes, I need you to know simple things like my two major inputs of blood to the brain are, and internal carotid. My internal carotid gives rise to what big arteries? Okay. My vertebral bodies give rise to what major arterial supply? Well, the basal doesn't really innervate much, but yes, basilar goes to, becomes PCA. Okay. So you kind of need to know that kind of flow, that kind of distinction, but then after that, I need to know who covers what. Because when we get to the cases, you're going to tell me, well, it was, we had some problems with floccular nodular function, and since it was very specific to the floccular nodulus, then it's most likely XYZ artery. And what's that going to be? The other one. ACA. Anterior, inferior. Okay. So cerebellar artery. So you need to have that rough idea because the flocculus is in the very front, but kind of the bottom part. The superior cerebellar kind of covers the top whole thing. There are very few things that can get a very singular symptom, like the superior cerebellar artery. I can't get an easy symptom set for you because then it covers the whole top, and then we divide the cerebellum from middle to less middle to lateral, and that's how we divide function. So the middle is very trunk, and then the lateral hemisphere is very distal limb control. So then it becomes a different question. Okay. So yes, you have to kind of know the divisions of the posterior and anterior circulatory system, but need to know your territories and what the ones that we talked about, kind of why I pulled them aside and made a stink over them in lecture. Okay. What else? Okay, let's go back to the first lecture. Okay, we did primary. So in the primary cortical areas, you have to have a sense of what they do, what happens when you injure them, obviously where their boundaries are. Okay. You guys seem to be quite familiar with the two aphasias. Lots of questions on that. You remember where this process? Oh, yeah.
I have a question actually back to the ventricles and blood supply.
Okay.
So like in your last slide, there's the list of terms, and one of them was talking about regulation of the extracellular environment regarding the cerebral spinal fluid.
Uh-huh.
Can we just go over that?
Okay. So you're talking about the blood-brain barrier, I think?
It's like,
Yeah, because
Yeah, I think
it's
so.
some protein or something flowing through the extracellular space, which is basically the blood. We have to consider there are three ways to get to be in the blood system that can then make their way to the brain. If I am extracerebral, meaning I'm in a blood vessel that belongs to the dura, it's not part of the brain, but it's in the dura, but it's close to the brain. And so we know that in extracerebral arteries, they're very fenestrated. They have small little holes and spaces between the cells, stuff likes to extrude out all the time. It's an important feature that they need to have. So now that it's on my inside feeding my dura, it's now bathing my brain. What barrier does the brain have to fend off stuff coming out of an extracerebral artery? What's the barrier? it's the arachnoid, not the subarachnoid. It's the arachnoid mater, the arachnoid layer, okay? It's the actual meninges. Now, if I am a choroidal vessel, because we know that the choroid plexus produces CSF, so we have to have a constant blood supply where it extrudes plasma from there, and then it filters through a couple other things and becomes CSF. How do I keep, and they're just as leaky, they're just as fenestrated. What is my barrier to keep stuff coming out of a choroid vessel from getting in, right, to my brain tissue, which is kind of already in my brain, but it's in the ventricle, which is choroid epithelium. Okay, so it's a lining in the ventricular wall. Okay, now my last one is intracerebral. These are vessels that have already punctured into, and they're flowing, and they're all over inside my brain tissue, because we certainly need blood in there. We know that they are not fenestrated. Well, I just gave it away. They are not fenestrated. That's the barrier. Okay. So they are made of, or they are arranged with tight junctions. And that's what keeps stuff out of an intracerebral. Blood vessels that are already in the deep depths of brain tissue. Felix.
Does the arachnoid matter, does it completely keep everything out, or there's something that leaks through it?
The arachnoid matter. The if it's on the outside, yes. But what's the exception?
No issues.
Nope. Where does the arachnoid not keep it out?
Sinus.
Nope. Nope.
Ventricular
Circumventricular organs. And there is that list that you need to be familiar with. That is where that arachnoid is not covering quite enough and allows things to seep in. And luckily the brain has kind of designed itself around those leaky spots, or the leaky spots arrange themselves in those locations to provide necessary information. So for example, the hypothalamus, which is a very busy part of the brain, needs a lot of information about your hormones, is a very leaky, it's a circumventricular organ. Yeah, Michael.
So do you have to know anything else about the circumventricular, or just the list? What that's what it goes.
Just recognize it. You don't have to, it's multiple choice, so I can't say, give me all the circumventricular organs. But my list may say, which of these is a circumventricular organ? So it's not as bad as memorizing the list, right?
Is there any way you can go through that list? It's not too long.
Oh, sure.
Maybe all the above, isn't it?
Let's see. That was in the first lecture, right?
Yeah.
Okay, here's the list. A pineal gland. Oh, oh yeah. Okay, so the pineal gland is dorsal, so it's up here, okay? And then we have the median eminence of the hypothalamus. That's pretty much at the base. It's where the tuber cinereum is. It's the base of the infundibular stalk, so that's also the median eminence. Posterior lobe of the pituitary gland itself, so that's why that sort of dangly part is red. The subfornical organ, organum vasculosum of the lamina terminalis, the choroid plexus, area postrema, and subcommissural. Those are harder to see. They are labeled. Here's the organum vasculosum, commissural area prostrema. It doesn't really matter that you know where they are. You can see that they're kind of very clustered in the very core of the brain. That's something to point out interestingly, but this is the list, okay? Yeah, Owen.
The cross section of like the third ventricle that you provided and like the borders of it,
Uh-huh.
how would you ask a question on that? Would you like provide a photo and be like, what is this pointing to?
No, I have no photos. How would I do that?
Would you ask a question on the borders?
Sure, why not? What would I say about that? I would say,
Like hypothetically, if you wrote a question.
yes,
on
I'm
this
starting to
exam
think,
on Monday.
what would be a fair question? Would be, what is, the entry point delivering CSF into the third ventricle? What's that? Okay. What is the main exit point of cerebral spinal fluid from the third ventricle? Okay. What is primarily making up the walls of the third ventricle? Not,
Thalamus?
Septum,
The
no,
thalamus?
too high.
The thalamus?
The thalamus
Hypothalamus.
and the hypothalamus are the main things that are making up the wall. So this is something we do in the lab. Is I always tell students, imagine this alleyway here is the third ventricle. It's just a slot. It's very narrow, okay? If this were the third ventricle, what should I be able to touch here? Okay. Thalamus. Hypothalamus may be down on the floor, but mostly at ankle high on the side. What would be up here? If I were tall enough and I could touch on either side, what would be up there?
Corpus callosum, yeah.
At the very top, I would finally reach the corpus callosum, but that's really way up there, okay? And then maybe way up on, what floor are we, the basement? On the first floor, right over here, I might start to see the septum pellucidum on either side, okay? That wall would be what? If my brain that we're in is this face this way.
Which way is this front back?
That's the front, my brain and the brain I'm inside is both in the same position. What would that wall be? I was say that again?
Lamina terminalis.
The lamina terminalis. So that wall would be the lamina terminalis. What would be at the ceiling or on the first floor, right on that wall?
Anterior commissure.
Anterior commissure. What would be on the floor? Optic chiasm. What would I expect to be here?
Oh, that's
It ought to be a big hole. What's the big hole at the other end? If that's the lamina terminalis, cerebral aqueduct. And then that, if I slid down that hole, I should go swimming right into the fourth ventricle. We have to make these mental images. Otherwise, it makes no sense to keep looking at pictures that will always be a little different. And you will always have, you know, like this doesn't look what I was expecting. But if you already have a preconception of what it should be, you'll find your way. I promise. It works every year. Okay? Okay. Okay, so we then go to the second part of that, the association cortices, lots of human-like function, like language. If I had frontal lobe damage and I couldn't remember where I just parked my car moments ago, what part of my brain do you think is affected?
Dorsal PFC.
PFC, dorsal lateral. What if I decided that I was going to drink from every one of your water bottles because I felt like it, because I could? What do you think is wrong with my brain?
Ventromedial.
Okay, so impulse control, suppressing inappropriate behavior, a lot of that personality, a lot of that colorful Phineas Gage behavior. Yes?
So if you wipe out the ventral medial PFC, would you see that grass root and stuff come back?
Yeah, it doesn't have to be just the ventromedial.
Okay.
But yes, that would be a fair guess. But you can lose a lot of cortical area and still get the grass root suck to come back. You can get grass root suck to come back if your buddy is super drunk. So usually my neuroanatomy class by spring, in the spring, you all go to the bar and you start doing all these neurological tests, because there are certain tests that only will reappear only when someone's super inebriated. That's one of them.
Wait, I have a question. So Phineas Cage was damaged ventromedial.
He was frontal lobe, so he showed both the dorsolateral and the ventromedial. He showed the impulsive behavior, the very bad personality, lack of commitment, all that executive function, and he had poor working memory.
Okay, and then what are you said there's like things tasks you can do on someone who's inebriated?
Yeah, I mean, so there is a cerebellar test. It's an ataxia test, which is, you all know why you would do it. You walk down a single line, right? So the heel to toe is a test of ataxia, okay? So it takes the cerebellum to do that. The other thing is nystagmus. So nystagmus is, okay, we're getting really way off topic, right?
It's about the brain.
Nystagmus is the beating of your eyes. And it's related to your vestibular system, your inner ear. And once it kind of gets filled with too much alcohol in the inner ear, it starts to think you're spinning, which you all have experienced the bed spins, right? You know what the bed spins are? You know that no matter if you close your eyes or you open your eyes, you're still spinning. But that's because it's coming out of the vestibular system. What you don't know is while you're thinking you're spinning, your eyes are doing this. Okay, so when the cop pulls you over, not only does he make you walk in a line, but he asks you to follow my finger. And if you follow his finger, that triggers the nystagmus. So as you're following one direction, your eyes are going like this, and it'll start to beat. And he's like, you're done. Because we know what percent alcohol you need in your bloodstream to start nystagmus, and it's pretty low. It's less than the legal limit. Yeah.
I have another off-topic question. I'm sorry. How does that work in people who have severe cases of albinism? Or those who...
Or albino?
Yeah.
Huh. Oh, you mean like how do their eyes function?
Yeah.
In albinism, they're only missing the pigment in their body. So their eyes are pink because you only see the blood vessels. That's why it's pink. It's not colored pink, it's the blood that's in the back wall, the retinal bed. There's a lot of blood back there because all your photoreceptors need to be fed quite well. And that's what you're looking at. Whereas everybody else has pigmented color in your iris, blue, dark brown, et cetera, et cetera. They cover up that red. But you've noticed when you take pictures, sometimes somebody has that red eye. That's because you got the perfect angle to get right into the pupil and hit the back wall. It's just reflecting the blood vessels. So in that case, the eyes are no different. They would follow the same rules.
I do have a friend whose eyes do move in that sense, though.
But that should be a vestibular thing.
Okay.
Yeah, not an optical thing. Yeah, it's connected to the optic muscles, but the driving force comes out of the vestibular organs. And we'll talk about that. It's my favorite lecture of the whole semester.
Did you mention orbitofrontal, prefrontal cortex, or did I make that up?
Yeah, no, the orbital frontal is the ventromedial. So it's that divot. Yeah, it's the divot where the eyes would normally sit. If you would kind of remember your whole brain, there are those two little indentations. That's where the eyes are. So that's the ventral, that's the bottom, medial, and they're also called the orbital frontal cortex because they're in the front and around the orbits. Okay? All right, let's stay on track, people. You're the worst. All right. Okay, ventricles and blood supply. That was the next lecture. Who can tell me what part of the lateral ventricle is in the occipital lobe?
Posterior horn.
Posterior horn?
Posterior horn? Posterior horn? Okay. I'm gonna have to cut you off soon. You're Hermione. And we're gonna have to.
I'm so
In the temporal horn, or in the temporal lobe?
Inferior?
The inferior one.
Inferior, okay. Any questions while we're playing this game? Okay. Sorry.
No, you're fine. I'm trying to think.
Let's see. So, if I were floating inside the ventricle, I started in the very beginning in the anterior horn, and it's very vacuous. But then all of a sudden, I'm in a giant cavern. Where can I be?
Atrium.
Good job. All right. Someone walk me through the ventricle from front to back in terms of flow. Who can do that? Michael?
Yeah, so it's choroid plexus in the lateral, then foramen and monorail, then third ventricle, then cerebral aqueduct to the fourth ventricle, kind of like down to the back, and then two Luschka is kind of out to the side, and then Magendi is like towards the back.
Excellent. Now, where am I at this point? Once I've gotten out of the Magendi and the Luschka, where am I?
So you're like in the subarachnoid space.
Okay.
on the
How do I get out of the subarachnoid space? How do I get to the venous? Yes, granulation or arachnoid villi, okay? So if you can do that, simple. You've got it covered. What do I get for CSF? What are the benefits?
Buoyancy.
Buoyancy. What else?
Cushion.
Cushion. What else? Fluid regulation.
Filter.
Filter. Little spatial buffering. It's kind of in some of your answers, but the idea of being able to absorb some of the pressure changes. Yep. My ventricular system has vulnerabilities. Where are they?
Small spaces.
Such as
Foramen.
foramen of Monroe, foramen of Luschka, Magendi, cerebral aqueduct. If I have a tumor or I have swelling, I pinched everything off. Let's say I have a tumor in the cerebral aqueduct. Who's going to be in danger? No, not everything.
First and third. Lateral
First.
and third.
Lateral and third. The lateral ventricle's in third. Only what's behind it, not what's in front of it. Okay. So if I have a fourth ventricle, let's say the cerebral aqueduct, the fourth ventricle will be okay. If I have a Magendi, it could be okay if Luschka can take over. But let's say I'm in the fourth ventricle, I plug them all up. Then everybody behind me, lateral ventricles, third ventricles are all, and that was pretty much the slide I had up here, the 2-year-old. Okay, so if I have a tumor blocking or swelling, blocking, let's say the foramen of Monroe, what kind of pathology is that? What do I get?
Hydrocephalus.
Hydrocephaly. What kind of hydrocephaly?
Non-communicating.
Non-communicating. Does everyone know the difference between communicating and non-communicating? Okay. Yes.
So you would only have hydrocephaly if it's in the lateral,
Nope.
or it could be any one of
Yep.
the ventricles? Okay.
Yep. Any kind of excessive fluid building up, no matter how small or large, is hydrocephaly. Okay.
Wait, question. What
Yeah.
would cause the communicating hydrocephaly?
So remember, the cerebral spinal fluid has a natural turnover rate. So for whatever reason, either the CSF is made too fast and it can't expel it fast enough, or the get it out of into the arachnoid villi into the sinus is too slow. So whatever those possible reasons are could create a communicating hydrocephaly, meaning there's no obvious obstruction, but there's an imbalance between the in and the out.
That would be less severe.
It probably less severe and less focal, like it would be the whole brain that's kind of taking it up, and so therefore it would take longer for a big amount of damage. Bridget?
Yeah, I just had a question, this is kind of random, but I know like in like kids when you have hydrocephaly, it's like their heads will like get bigger because they have like smaller skin. But when you're an adult, that just creates pressure, but what if you just like don't get that taken care of? Where does that
You pretty much die. Yeah, no, hydrocephaly as an adult with your full skull intact, if you don't address it, and there's no way you don't address it, you're gonna suffer the most painful headache you've ever, they call them lightning headaches. Sometimes people describe it when they have a lumbar puncture, they take spinal fluid out to sample. Even removing a few drops is enough pressure differentiation for someone to feel the extreme, oh my gosh, my brain has never felt that pressure change, and will have the worst headache in their entire life. So there's no chance you let that go. But unchecked, having brain swelling like that is definitely death. It's not a question, it will be death. Felix and Ada.
So, piggybacking off of that, babies, if they're treated fast enough, it's not damaging, but if it's not treated fast enough, it can
No,
cause brain
it's
damage?
always damaging. They have
Okay.
to be treated.
Okay.
If the babies express it before their skull plates have fused together, their heads and their skull will grow in turn. So they'll have very big skulls, but unfortunately they'll have a lot of fluid in there, and the more fluid it means there's less brain. So there will be cognitive problems, even with babies who are managing to absorb or adapt to that change. And obviously if you don't catch it and you have the pressure buildup, or you don't catch it in time, you still suffer, they often suffer some type of cognitive deficits and learning disabilities and all of those things that come along. Yeah.
Okay, so do they, like, you just remove it by like draining it?
Yeah, you put in a shunt.
Okay.
So it's basically a little straw, and it's sitting in a ventricle, and it's anchored to your skull, and then the rest of the tube is kind of fed through underneath your skin, right into your stomach, and it's there for life. And it's constantly drawing the fluid away.
I saw something with that.
Yep, so I think we have in the Gross lab, and is an example of the skull with the shunt that Dr. Cullen keeps to show. So you can see the shunt kind of screwed onto the skull cap, is the little rubber straw still on there.
Are these like lightning headaches similar or like worse than a migraine? I guess?
Yes, no, it just feels like you put your finger in an electrical socket. It's kind of thing. Bridget.
So wait, if you have that, like a tumor in like a 19 day, you can't like take that out?
Well, if it's easy, if you can get to it. I mean, a fourth ventricle or third ventricle tumor, you got to go through a lot of brain to get there. So tumors are different. Like they most always want to get rid of the tumor. But if it's some other reason, then they'll try to put a shunt and address it that way. But yeah, two different conversations are starting there. Anybody else? Yes.
Do you have any spare case studies for us to practice with?
Oh, we have tons of. We will get to them. But you don't know enough anatomy yet. It's very hard to find case studies that you can solve so far. So the more we learn, the more case studies you can have. But the ones you got were super, super, super simple, right? You don't need to know. And here's the other thing, finding case studies where you don't need to know any medicine is even hard. So you don't have any other medical education. It's a hard thing to sift through what you don't need to know about drug interactions and genetics and you know what your pancreas is doing at the same time, and it's like, yeah. So yeah, we got lots. It's going to be lots of fun. You're going to play doctor very soon, Michael.
So can you, yesterday, this is like Wednesday, when you were showing us like, if your like ACA is blocked, then you're gonna have like leg weakness,
Uh-huh.
and, like, the crazy hand.
Yep.
Can you like tell us what was the other one?
Okay.
Like what are the symptoms of each one?
All right, let's go back over the functional. Okay. So the thing to know, what we've covered is all the cartography of the brain, like all the regions and so forth. Now we got to put them together. This is functional neuroanatomy. Keep that in mind. So take your homunculus, take your understanding of cerebral cortex territory and who's association and who's primary, take all that, plus our vascular territories, and now we're gonna mush them together. So, remembering your homunculus is gonna be very important. Remembering where, like, it's not just to know that Broca's is 44-45, but where is 44-45? What lobe is it in? Frontal. Okay, you need to be a little faster, guys. Wernicke's, what lobe is it in? Thank you. So things like that, okay, because you're going to want to associate it with a vascular start point. Anterior middle or posterior cerebral artery is usually where we're going to start. A couple of times I tried to trick you in the class example. You had to back up to the carotid, but that's okay. You guys handled it well. Okay, so if we have anterior cerebral artery, which one? Which sub-branch is most likely to produce some visual deficits? The what? No, it's the anterior cerebral artery. I gave you that. Which branch of the anterior cerebral artery is most likely to give me a visual deficit?
Pericolossal.
Why?
Because it hugs and it goes back.
That's right. Pericolossal is more ventral, but is the one that travels further back. So most likely to pick up some of the occipital lobe on the very inside, medial side. So you want to do that kind of thing. Which artery is most likely to give me thalamic pain syndrome? Even though you don't know what that is, it's obviously in the thalamus. What is it? Okay, be more specific. Yeah, you can't do that. You can't. This doesn't get you the answer on the exam. What's this? What is it? No, not the loop ones. The lenticulostriae. So the lenticular nucleus is another name for globus pallidus. So that's where we have lenticulostriae. The striate is talking about the putamen. There's a lot of striate. The striate is also the visual cortex, but in this case, the putamen is looks like like a football, but then the internal capsule tries to go in it like a bike spoke. So it's white, gray, white, gray, white, gray, white. So it looks like stripes. That's why they call it striate. Okay? Yeah, anatomists are just not very imaginative. If I had agraphia and alexia, but I could speak and understand language just fine, what artery do you think that is? Hermione?
PCA, also agree.
PCA? So where's my 38?
Is it 39?
Or 39, sorry. Where's my 39? Yeah, 38 is more medial temporal.
Oh,
It's in the parietal lobe?
No,
Almost, it's in the occipital lobe.
no.
It's in the temporal lobe?
It's in the temporal lobe?
Are you sure? Oh, yeah.
Is it?
I don't know. It looks like it's between all three of them. Hey, I'm not a PhD.
Maybe I'm thinking of the wrong one.
No, you're definitely right.
Let's see, that was in,
Just so easy.
Does it depend like person to person? Oh Lord.
I didn't realize it was going to be so specific.
am I thinking 38? Oh, I'm thinking 38. Oh, never mind. Okay, so it's 39. Which one do I think it is? So I would probably take middle, inferior. But PCA could reach around, it just depends who gets there first. And in that individual, who's got more vascular right on that spot than others. So someone, in one case, might be MCA, and the other one might be PCA. Sorry, I was really going for 38, and I had this in my mind. If it were 38, yeah. Okay, sorry, my bad. Okay, let's talk about what do I generally get as my major deficit if I damage a posterior cerebral artery? Huh? Homonymous hemianopia. Right now, it doesn't matter, homonymous, hemianopia is the same for you. Later, we'll have a different kind of hemianopia. It's a bitemporal hemianopia, where you don't lose vision on the right side of each eye, you lose the outside, the temporal side. It's a bitemporal hemianopia. That comes a little later, but that's okay. So yes, PCA generally gets you a hemi loss of vision. Yeah.
Do you also get hemianopia in the lenticular triangle?
No, not lenticular, but you can get hemianopia with a middle cerebral artery inferior. Does anyone happen to know from past anatomy why you would get hemianopia with a MCA inferior infarct? You guys remember? We will learn it, but it comes very near the end of the semester. Do you guys remember Myers loop?
No.
No?
Not really.
Just remember, it's part of your optic radiations. So from the lateral geniculate nucleus, you take the optic radiations to the visual cortex. But there's two sets, and one set kind of travels inside the temporal lobe. So if you clobber the temporal lobe, you could have a hemianopia. And if you're very clean and only hit the Myers loop and not the superior optic radiations, you get a quadrantinopia. So you only lose a quarter. Gets crazier and crazier. Okay. Let's see. So, if I have hemi-neglect, who do you blame? What?
Middle cerebral.
Middle cerebral, what side?
Respective side.
Right side?
Just
The left side?
The right side.
What about the left side?
I like the
The
left
right side is dominant, and so it can compensate for left damage.
So if I have left MCA, am I gonna get hemi-neglect?
Probably not.
Right. That's why it doesn't work well. We don't have right-sided hemi-neglect. It's very rare, or it's very transient, like it goes away in a couple hours or a day. Well, we do have left-sided. It's always left-sided hemi-neglect. If I have aphasia, who do I blame?
Middle or
depends on the type of aphasia.
Okay, if I didn't care, it would be
I call middle.
middle, right? Because that'll get them both. If I said Broca's, it would be,
Superior division.
yep. If I said Wernicke's, it would be,
Inferior
okay.
division.
We got that pretty quick, okay. If I have gaze preference, my eyes locked to the left, my gaze preference, what do I have?
Think you'll straight.
No, left, and my eyes are to the left. Liz? Superior, left. MCA? Yes. Because it's, where is my frontal eye field? It's Brodmann's area, 8 and 6. So they're in the frontal lobe, yes.
would you see deficiencies like in like the prosody,
Prosody?
Yeah.
Uh-huh.
if it was like instead of like if it was like right middle cerebral, would you then have like the motor presidia or the sensory?
Yes. So that would be a great question. I have someone who has thinking. I already wrote the exam, so you're okay. The person has normal capacity to understand and produce speech, but doesn't seem to get my sense of humor or know when I'm asking a question, and is speaking to me in a very robotic monotone. See, so we've lost the prosody side, and there's motor aprosodia and sensory aprosodia. Inability to make sing-songy, lyrical speech, and inability to understand it.
And that's on the opposite side of Wernicke's?
Yes, no, it would be Wernicke's on the non-dominant, which in the majority, if I were betting, would be on your right side in this room. Right?
When you said gaze preference earlier, does that mean they can't move their eyes to the other side, or does it mean that's their default?
No, they're just stuck.
They're just stuck.
Yeah.
You can try, but it's like you can kind of get them there, but they'll just go back or something. Or
Maybe,
okay.
but yeah, and they don't want it there either.
Yeah.
They'd like to look forward. That is the frontal eye field.
Right.
Yes, that's what's causing that gaze preference. Okay. If I have sensory loss in my face and arm, what do you think?
What side?
Okay, if I have sensory loss in my right face and arm. Left MCA? All right. What if I went up to, oh, somebody, give me your hands. I went up to Alexis and I just slipped my hands in her hand, my finger in her hand, grabbed on. What do we see? Okay, she's doing it with her left or her right hand.
Frontal release.
So where do we think is going on?
Or left
Left
anterior cerebral.
anterior cerebral artery, right? Because we're seeing it in the right side. So where the reflex occurs is also kind of important. Give me another dramatic symptom with ACA infarct. Sophie? Can you think of one? Crazy.
Alien-like.
Alien hand syndrome. Owen, give me another one. Owen, give me another one.
Could I?
Yes.
Let me think about this. Oh. Someone just stare at me.
Yeah. Come back.
Interior?
No, I know it's anterior cerebral, but give me another symptom that I should expect with it.
It's an interior infarct.
Yep. We did alien hand syndrome.
That's the only one I know.
Better crack the books, Michael.
The rooting, the suckling, all that stuff.
Frontal release signs, JD.
Incontinence.
Incontinence. Abulia. Do you remember abulia? What else is on my list? Anybody else got another one? Bridget? Apraxia. Okay. What else? There's some more. Impaired judgment. Okay. Part of abulia, that's the lack of willpower. What's another one? Flat affect. Okay. So you kind of want to be familiar with those. They will crop up here and there throughout the cases. How do we get, I know we talked about it in the very beginning of class, maybe while you're coming in. How is Alexia without agraphia?
Damage to the splenium in the posterior cerebral artery.
Which one? Okay, I will remind you in this class and in all my exams, going from here to the final, the left and the right adjective is so important. Okay? So you can't just tell me left.
Right? Yeah.
left posterior cerebral artery that includes the splenium, which is the middle thing, so it doesn't have a left right. Does everyone agree or disagree?
Agree.
So Alexia and Agraphia are the right sides of the cross, or what side is BA 90 left?
Maybe last for learning keys and learning keys is all.
So Alexia and Agraphia, where that center is found is on.
Okay, well, I'm just gonna use this page because it has the least amount.
Okay.
So.
Yeah, learning keys on the left, so the right, this is
Okay.
the right, so I can get both.
So we have our two hemispheres, and we're connected by our corpus callosum. And JD points out that we have to have a left PCA infarct, so that takes out my left occipital lobe. But I also have to have damage enough in my splenium, okay? And this will get me Alexia without agraphia. So this is left, and this is right. So, who wants to explain the pathway? Alexia, to read, I have to have a word presented to this patient. Felix, what happens?
So there's something in the left visual field that will cross over at the optic chiasm, and it'll go down to the right occipital lobe.
Okay, so it's going over here,
Yep.
then?
And then it will try to go across the corpus callosum, but it can't because of damage to the splenium.
Okay, but how do I get agraphia?
Because a Broca's undisrupted.
Right, so I have my Broca's and my Wernicke's here. And so it doesn't matter which hemisphere is sent. Both hemispheres are sent the word, right? So when the right hemisphere gets the word, it tries to send it over, can't, because the splenium is broken, can't make it to Wernicke's. When the left hemisphere gets the word, which it does, what happens? We're already broken. So we can't see it. So we have cortical blindness on this side. So it doesn't matter which side the word is presented in this case. Right? Either way, the word is not getting to Wernicke's, either because the tissue is damaged or the passageway is damaged. So we get Alexia, the inability to read, but because Broca's doesn't depend on this splenium and is perfectly fine, agraphia still works, or agraphia doesn't exist. Bridget.
If it was on the first side, would it just be like, would it have sensory processing, would it have motor processing?
I didn't hear the first part of your
If
question.
it's on the other side, like if we switched it to the other
Ah,
side. would
right.
it be-
So if I had this damage, you mean?
Yeah.
Yeah. So in that case, the word would make it to my left hemisphere and make it to Wernicke's, and I'd have no problem with reading or writing, and we wouldn't notice this.
But
Little
would you have
interest.
sensory processing? You wouldn't have sensory processing?
Well, you would still have hemianopia
Okay.
for the left side, but it wouldn't impede you with reading.
Yeah, but for like processing, sorry.
Oh, no, because it still doesn't depend on this. The only thing that might depend on is if you had to read something out loud and maybe make it lyrical,
Yeah.
maybe that would have a problem because it's, you know, the word from this side is not traveling to this sensory Wernicke's, and then but other than that, that would be a really unique way of testing that feature. Yeah. It would be an unusual way to detect it. Okay? Excellent, excellent. Oh. Way over. All right, don't you guys have a life?